So, welcome once again to another session of the Liver Transplantation series on the LGS Forum. Tonight, we look at one of the specialities which has helped liver transplantation to achieve the success it has. Intervention radiology was a nascent field 3 decades ago. It has grown in leaps and bounds, and its curve sort of parallels that of liver transplantation itself, with each field being complementary to the other. A close working relationship between the intervention radiologist and the transplant team has always been and continues to remain an essential component of a successful transplant program. Their main role in the management of a chronic liver disease patient is to decrease the dropout rate from the transplant waiting list or to bridge the time to a transplant itself. This is done by managing the sequelae of portal hypertension and of course in hepatocellular carcinoma. As shown by some centers in the Far East, it has some role in intraoperative as well. In the post-transplant period, the main advantage of intervention radiology is the ability to treat the complications in a percutaneous manner, thereby reducing the need for further surgery and preserving the function of the transplanted liver itself. So the role of the intervention radiologist in the management of these fragile patients has increased and will continue to do so with developing technology. And as a surgeon, it is for us to have a very good understanding of this key support specialty. To provide us valuable perspectives in this ever-progressing field will be our speaker today, Dr. Deepa Shree. She heads the interventional radiology vertical in Professor Ella's team. Having initially trained as a physician in the UK, Dr. Deepa went on to complete her fellowship in radiology and CCT in the UK, along with the European Board certification in intervention radiology. She is also the program director for the fellowship in intervention radiology at our institute. Dr. Deepa dons many hats. She's a certified psychologist, a Zumba instructor, a fitness enthusiast, an author, and motivational speaker, amongst others. One among the many feathers on her cap was that she was chosen to represent India as an international scholar at a global platform in the United States. Over to you, Dr. Deepa. The floor is yours. If you can just share your screen now.
Thank you. Thank you so much, Dr. Ashwin, and thank you so much for having me over here. Thank you all. So today's topic, it's interventional radiology, management in pre and post liver transplant cases. It's a huge topic. I mean, as you all know, there is so much to talk and there is so much to squeeze in 1 hour. So I hope I do some justice to the topic, but I have tried to put in as much as I can. And I often feel that the best way to work in any hospital or any way for that matter to deliver the best possible care to the patients is to be friends with everyone. I think that's the best thing, and the teamwork. I think as long as we have these two components together, we can always find that missing puzzle and we can find the solution to any problem for that matter. So without wasting time, I'll just move on to the kind of interventions that we do in the pre-transplant scenario first. And I've been told in the next half, I will be talking about the post-transplant scenario. So coming to the pre-transplant scenario, the kind of cases we get to do, I'm actually privileged working with Professor Rayla and team because the number of cases I had seen after coming to India, it's been huge, huge numbers. I mean, I didn't realize that I'll get to see so many cases and I'll get to do so many cases after coming over to India. And so one of the, I mean, we all know, I mean, this must be hanging in every department, the BCLC staging. So I'm not going to go into details of this particular, the BCLC staging, but we all know for the sake of juniors who are attending, there are some of my juniors who are attending. So apologize for the seniors in the group who might feel this is very basic. So TACE is predominantly done for intermediate stage HCCs as far as the BCLC staging is concerned, but we also offer as a bridge to transplantation. So it's not necessarily the intermediate stage. Sometimes we can also, can you all hear me? The connection is unstable. Can you?
We can hear you, but it's
can you hear? Okay. It's breaking up?
Yes, it is actually.
Okay, just give me a Few seconds, yeah, just one second.
Yeah, it's better.
Better? Okay, fine. Um, right. I mean, any point if you feel you're not able to hear me, okay, just let me know in the chat box so that I can do something about it. So moving on further, so I mean, this is the BCLC staging, which is a pretty basic staging that I've just put in there. So the whole point of this particular thing is to tell people that it's not just for intermediate HCCs that we offer TACE. And if you see, even for early HCCs, we have liver transplantation, and sometimes as a bridge to transplantation, we can offer TACE or TARE. So what is hanging there is probably not that needs to be followed all the time, and it varies. I mean, it kind of differs from case to case. So if somebody has newly diagnosed HCC, if it is confined to liver, if it is resectable, they go in for surgery. We all know that. If it is unresectable, then if it's less than 5 centimeters, the Milan criteria, we all know about that. And child C, they go for transplantation. If it's child class A or B, you either go for TACE or CERT. Having said that, even in child C, we do offer TACE, we do offer ablation, we do offer TARE in a small subset of patients. So it's not necessarily childs A and B. In our practice, we have seen good results even in certain subset of patients who belong to child class C. So when it comes to the TACE procedure, the technique that we follow is something that I'm going to show you all in the next couple of slides. And this is a child's grading. Quite often, I look at the Okuda staging when a patient comes to see me in the clinic. And based on this, I decide on whether the patient needs to go for TACE or TARE. Usually, the tumor size society's albumin. It's quite handy when I'm in the clinic or when I'm seeing a patient. It's full staging just to see, and based on this, we decide on what treatment to go for. Because even in TACE, there are different types of TACEs, which I'll be talking to you all. And again, ECOG performance status, it really matters when it comes to deciding on TACE or TARE treatment. Sometimes we offer, if you offer TARE for people who are ECOG more than ECOG 2, they don't do really well. So it's very important that we understand the ECOG performance status as well. And this really matters to deciding on the treatment choice between TACE and TARE. And when it comes to TACE, there are different types of embolizations that we do. At Rela Institute, we follow conventional chemo. TACE is usually used for certain subset of patients, but conventional chemoembolization, which involves lipidol plus blocking agent, it has given us fantastic results. So conventional chemotherapy is almost equally as good as. So I stick to conventional chemo. Most of my patients, except for that they might have a lot of systemic side effects, that's when we resort to the depth case. So this is a CT of a patient wherein you can see that there is a large shunt. Sometimes when somebody has got a large arterioportal shunt, go in any treatment, because I have seen a lot of patients who come to us with an arterioportal shunt. I don't know whether you could see there. So that is the arterioportal shunt in somebody who has got CC. Generally, such patients are not treated, but we actually, what we do is we block off the arterioportal shunts and then still go ahead with this artery or TARE if required. And have a nice round lesion like that, the most important thing is to look at the CT and plan your procedure before you just go ahead and do it. So here you can see that there is a very nice tumor which is there, and it's quite demarcated. It's got a pseudocapsule, and what you see is it has got an aberrant supply from the SMA, not an aberrant supply. It's a variant anatomy from the SMA. So it's very important, rather than just going in and jumping into the angiogram, we need to look at the CT and make sure, look at the arterial supply here. You know, the variant anatomy is coming from the SMA, so you don't waste much time whilst actually doing this. We set the trolley up, and quite often we use the ultrasound guidance because most of these patients are thrombocytopenic. So it actually helps us if you use the ultrasound so that we don't puncture the, double wall puncture is avoided when you use the ultrasound. So patients with low platelet, the bleeding complication is fairly minimal if you use an ultrasound guided puncture for a certain group of patients who've got low platelets. Otherwise, you can just go for a blind puncture. And once we puncture the artery, we just get inside, and this is the angiogram. What you see is a tumor blush. So we know that it's SMA supply, it's hepatic arteries coming off the SMA. So I know where to go in. And as soon as we go in, you see a nice tumor blush. And once we identify the tumor, this is when I actually decide whether to go for a conventional TACE or a depth TACE at this point as well. Sometimes you don't see a very clear arterial blush. If you don't see a very clear arterial blush, we should not be doing depth TACE. Depth TACE is drug-eluting beads. We need to be very, very super selective when you actually use depth TACE, because we just cannot go in and inject everywhere this particular depth TACE, because depth TACE, what it does is, it not only kind of treats the tumor, it also blocks the tumor. It's got chemotherapy plus blocking agent mixed together. And that is the reason why we are not supposed to do depth TACE if the lesion is not well visualized. In this case, I prefer to use the lipidol, and this is how we mix the lipidol. The orange substance that you're seeing, actually the doxorubicin, the chemo agent. So we mix lipidol and doxorubicin in a steel bowl. The reason why lipidol and doxorubicin in a steel bowl is only because lipidol can melt the plastic. That is the reason why we mix it in a steel bowl, and after that we just take it into a syringe and we follow the lipidol injection with PVA particles. This is the embolization aspect of the TACE. As we all know, TACE has got the chemo aspect and it has got the embolization aspect, TACE. So for the therapy with lipidol and doxorubicin, followed by the embolic agent, which can be PVA, it can be gel form, it can be any of the agents to block off the blood supply to the tumor. So this is what we do. And this is a large tumor. This is not in a pre-transplant setting, but I just wanted to show that we go to any extent when it comes to treating these tumors with TACE or TER. Sometimes, you know, we have even downgraded tumors from 7 centimeters to 5 or 4 centimeters so that the patient is suitable for transplantation. When somebody has large tumor, we also use combination treatment, which I'll explain to you as we go along. This is just TACE therapy in somebody who's got really, really large tumors, and that is a lipidol deposition inside the tumor. Where on CT, lipidol looks bright. So what you're seeing there is a deposition of the lipidol on the CT scan. This is another tumor wherein you can see there is a tumor blush, and that is a deposition of the lipidol inside the tumor. So as you can see, this is an arterial phase. On the previous, this is an arterial phase where the arrow is pointing to. You can see that that is a viable tumor inside the tumor. And when we inject lipidol, what you would see is that viable tumor takes up the lipidol, and you will see the deposition of the lipidol on the arterial phase, on the plain CT as well. So we know that this is a very good response following TACE. And this is what I meant by depth TACE. Depth TACE is nothing but drug-eluting beads. So what you see is the doxorubicin and the beads are suspended in a solution. So when we actually inject this, it kind of blocks off the vessels immediately. And that is the reason when we are not certain about the location of the tumor, if we are not really sure, sometimes you get this wishy-washy appearance on the CT scan. You're not really sure where the tumor is and what is supplying, whether this is a tumor or not. You have got a lot of doubts when we look at certain CTs. And when we have such a scenario, it's better to avoid depth TACE. It's better to go for conventional TACE, because lipidol, if it is taken up by the tumor, then we know that it's definite HCC. Sometimes lipidol is not taken up by tumors. Early HCCs, they do not take up lipidol because the Kupffer cell activity is still present inside the tumor. So it's only in a little bit of a later stage HCCs you would see the lipidol deposition. So we can actually differentiate whether there is a tumor inside the liver or not by injecting lipidol rather than going in for depth TACE or the drug-eluting beads. This is a young boy who had 2 tumors. You can see subtle tumor blush. One at the top end of the liver and one at the bottom end. This was in segment 6, and I think the other one was in segment 7 or 8. So what you can see is a nice rounded tumor blush. For this child, I think child was only 5 years, if I remember, 5 or 8-year-old child, if I remember correctly. This was a couple of years ago. For children, we wanted to avoid systemic side effects. Generally, conventional TACE with lipidol can give few systemic side effects. In children, we do not want that, and that is the reason why I chose depth TACE in this particular child. So when we actually do TACE with depth TACE, you don't see any deposition of the lipidol. You would just see a blush like that. This is following the treatment, following the depth TACE. This is how it looks on the angiogram. And we choose depth TACE for really elderly patients and also for children. So that's about TACE, which is a combination of which could be either conventional or depth TACE. Now, what predicts the hepatic failure rate? What predicts the post-procedural mortality post-TACE? More than 50% of the liver volume if it is replaced by tumor, if the LDH is high, if the AST is high, if the bilirubin is more than 2. Ideally, in our institute, I mean, for me, the bilirubin threshold is more than 3.5. I mean, we can even go up to 4, provided we are super selective. So we have even done patients whose bilirubin was more than 4, but that is very, very, very super selective taste. So with advancement in technology, I think all these parameters, and we can actually mix and match, and we can, it's a case by case basis. We can select the cases and we can choose the right treatment for them. Whatever is written as a gold standard, whatever the literature says, it probably doesn't hold true when it comes to patients because of the advancement in the technology. We have got really, really small microcatheters. We can reach almost very close to the pseudocapsule of the tumor. So what they say in the literature right now is probably doesn't hold true, because they say bilirubin of more than 2, you're not supposed to do this. But I still go ahead and do, because we have microcatheters which are really small and we can be very, very super selective. So, and I think the individual abnormalities of these formats have not been to predict the adverse outcomes of chemoembolization. A very short, a few slides on TARE. So Y90 microspheres are usually used in TARE procedures, as we all know. It's a pure beta emitter. The Y90 drug that we're talking about is a pure beta emitter. And it's got this, I mean, this is pretty much, in terms of the technique, it's pretty much similar to TACE. How does TARE differ from TACE? I'll explain to you all. What we have is a Y90 microspheres here, with a half-life of 64.2 hours. The size is 20 to 40 microns. So they're very, very, very small particles in terms of the size. The range of penetration of these particles is 2.5 mm. Quite often patients ask me after the TARE procedure, can they sit next to the patient? Is it going to penetrate out of the body? And is it going to harm us? A lot of questions from patients. The range is only 2.5 millimeters. So it gets inside the tumor and it doesn't get out of the skin of the patient. So we really don't have to worry about this coming and harming the attenders or anybody for that matter. And there is a local tumor dose rate as well. And these are all the different parameters that we look at. The most important thing, I think all of us know all the other things, but the ECOG performance status is very, very important. Sometimes there's no point really offering TARE for patients with an ECOG status more than 3, or if their child C, again, the survival rate is very bad with TARE. And if you're wondering why I'm talking about TARE in the pre-transplant scenario, there are a lot of patients for whom we can do TARE instead of TACE, provided they are financially viable, provided they can, they are financially stable enough to, to go for TARE treatment. We can definitely offer TARE. But fortunately or unfortunately, our TACE results are pretty good. And that is the reason why we often don't use TARE. But if you look at the other countries, they have been offering TARE instead of TACE, even for early HCCs. So that is the reason why I just wanted to, tell you a little bit about TARE. And we also know this is one of the patients for whom we offered a TARE, wherein you can see that this was a 28-year-old patient, if I remember correctly. And what you can see is the entire left lobe has got diffuse HCC. And his AFP was sky high, actually, and it's quite diffuse HCC. His portal vein was patent, and this was pre-therapy. So we offered TARE, and what you can see is that the entire left lobe is completely shrunken. So this is a radiation lobectomy that can be offered for patients, especially if they are young patients. You can beautifully kind of take out the entire lobe. It's pretty much a lobectomy. So this is what happens in TARE. So it is an excellent treatment for diffuse HCCs. I don't believe in TACE for diffuse HCCs. TARE really does wonders in patients who have got diffuse infiltrative HCCs, and if the patient has a malignant thrombus. Of course, if the patient has malignant thrombus, not suitable for transplant. But if it's a diffuse infiltrative HCC confined to one lobe of the liver, we can definitely kind of destroy the entire lobe with TARE procedure. So this is one such case, and this was 8 weeks post-therapy. You can see that you no longer see the tumor there, and his AFP just fell down. So it was 70,000 to start with, and I think it came down to 7,000. The next treatment modality that I wanted to talk about was radiofrequency ablation in a pre-transplant scenario. Radiofrequency ablation, again, I think people have got this misconception about the fact that there can be tumor seedling when we penetrate the capsule. So at our institute, we don't actually offer ablation pre-transplant, but I'm sure there are a lot of other institutes wherein they offer ablation, whether it is RFA or microwave ablation. They offer ablation pre-transplant as well as a bridge to transplant, because again, the technology is fairly advanced now. We have something called as a, to avoid the tract seedling, we can burn off the entire tract. So we don't have to worry about seedling of the tumor or the deposition of the tumor along the tract, including the capsule. People don't want to disturb the capsule. They feel TACE is a lot better than RFA or microwave ablation. But with the advancement of the technology, the risk of tumor deposition, the risk of something seedling along the tract is fairly minimal with this approach. So that is RFA, and I don't have to go into the details of the RFA, but it's a beautiful, beautiful technique for people who have got solitary liver lesion. In fact, up to 3 or 4 tumors we can actually, treat with RFA. And now at our institute, we have microwave generators. So microwave ablation is done for tumors which are above 5 centimeters. RFA has got a limitation because we cannot treat tumors which are more than 5 centimeters with radiofrequency ablation. And again, if the tumor is lying right next to portal vein, if the tumor is lying right next to hepatic vein or cava, RFA is usually not very effective because of the heat sink effect. The heat sink effect is not great with microwave ablation. That is the reason why microwave ablation is preferred if the tumor is kind of marginal. If it is around 5 centimeters and let's say the patient doesn't want chemotherapy, then we can definitely offer microwave ablation in such cases. Even if the tumor is lying right next to a vessel, it's not a problem. The only downside of microwave ablation is it has got really, the amount of energy generated with microwave is probably more compared to RFA. And that is the reason, if there is a solid viscera or if there is some kind of a hollow viscera lying right next to the tumor, for example, if a tumor is in segment 5 and if there is a GB or if there is a bowel coming there, then we might have to do hydrodissection kind of to push the bowel away. And so microwave ablation is a little risky when you have a hollow viscera lying right next to it, but otherwise it has got its own advantages in terms of the tumor size, in terms of the heat sink effect. It is definitely a better treatment modality compared to RFA. I'll just skip this. So we use something called as a combination treatment. The combination treatment is using TACE and microwave ablation, TACE and RFA together. This is for tumors which are, let's say, 6 centimeter tumor. You have a 6 centimeter tumor and you want to downstage the tumor to, let's say, 4 centimeters. What we can do is we have a combination therapy using a combination of TACE and microwave ablation in the same sitting. We can actually do wonders. So this is one such patient, pre-procedural CT. Actually, it's not very enhanced. It's not a very vascular tumor. I mean, unfortunately, I don't have an arterial phase here. This is a CT, which was a little bit of a delayed phase, wherein you can see that this is the area of the tumor. So I felt TACE may not be very effective if the tumor is not very vascular. TACE is not going to be very effective. So the best modality if the tumor is not very vascular is go for microwave ablation. And if the tumor is more than 5 centimeters, probably microwave ablation has got a better way of treating this tumor than doing TACE alone. So what we did is we used a combination therapy. So in the combination therapy, you use a microwave needle to burn the central part of the tumor, and the peripheral part of the tumor is kind of taken off by TACE. So this is the deposition of the lipidol in the periphery of the tumor. And what you're seeing in the center of the tumor is a necrotic material from the microwave ablation. So this is a combination therapy that we have used. I think we did about 20 cases, and of late we haven't been doing, but we can do it even in the palliative setting, not just a pre-transplant. So again, a tumor as big as this can also be treated. You can see the amount of necrosis on a 1-week follow-up. There is almost complete necrosis on a 1-week follow-up. This is a pre-procedural CT, and this is a 1-week follow-up CT. And this is yet another tumor. There was a nice blood supply. And again, in this particular case, you can see the amount of necrosis that you get with microwave ablation. It's unbelievable. And it's actually very safe. And patients, they don't have the side effects of chemotherapy when you go for ablation. And this was a neuroendocrine tumor that we treated actually. So you can see a very large tumor which was sitting there, and you can see that it's a fairly large amount of necrosis. The white patchy areas that you're seeing is actually not the enhancement. It's actually the blood products following the ablation that you see. So again, there is a complete tumor necrosis. This tumor was about 12 centimeters. So this is a neuroendocrine tumor treated with microwave ablation. So moving on to tips. As a bridge to transplantation. I mean, again, tips has got, I mean, they did a study wherein they felt that there is no negative impact on the perioperative or the post-operative outcome parameters, but it definitely leads to significant reduction of the hepatic venous pressure gradient. So especially people with refractory ascites, people with variceal bleeds, TIPS should probably be offered as a bridge to transplant, although it has got no effect on the post-operative outcome or on the perioperative outcome or on the survival rather. So again, the other scenario wherein we offer TIPS is in the context of Budd-Chiari syndrome. So, this is one particular paper wherein they have shown that they did a long-term follow-up study after the successful TIPS placement in a pediatric patient with Budd-Chiari syndrome, and we had one such case which I will be showing very shortly. I'll skip this. I don't want to go into the details of the TIPS set. I suppose this is for interventional radiologists. One thing to understand with TIPS is, again, people always say they're worried about the patency rate of TIPS. And again, with the advancement in technology, whatever the literature says, it doesn't hold true right now. Because nowadays we have, really good stents available, but the numbers are not enough to write another paper and kind of demonstrate to everyone that the patency is fairly good. But if you see the kind of stents that we use right now, a fairly really good stents with a good patency rate. And in TIPS, what you see is you have something called as a covered portion and an uncovered part of the stent. So this is how the TIPS stent looks. So what you have is the one which gets inside the hepatic vein is a covered portion. The one which gets inside the portal vein is actually the bare stent. The reason why we have the covered portion is to avoid the neointimal hyperplasia or the smooth muscle hyperplasia because of the leakage of the bile juices inside the liver. Because we are creating a tract inside the liver, in order to avoid the neointimal hyperplasia, the covered portion is actually lying inside the liver. So the risk of that getting thrombosed is very, very less. And the one which is inside the portal vein is actually bare stent, because sometimes you have the left portal vein coming there. So that in order to ensure the patency of the left portal vein, we deploy the bare stent inside the portal vein. The covered portion is lying in the tract and it extends all the way up to the cavo-venous junction. And the way the TIPS procedure is performed is it's fairly simple. We just come from the jugular approach, and this is a tip set that we use. And so this is from the cava into the hepatic vein. And following that, we check the HBPG to look at the pressures pre-procedure. And we use the ultrasound guidance to puncture the portal vein. And once the portal vein is punctured, we take a small wire inside the portal vein. Now the track is created, and we balloon the track. The entire track is ballooned using a 6 mm and an 8 mm balloon. Generally, 8 mm would suffice for putting a 10 millimeter stent, because we want to downsize the stent. You don't want to put a big stent so that the patient gets into encephalopathy. So we normally prefer an 8 millimeter track dilatation, although we deploy a 10 mm stent. Just in case the patient requires dilatation later on, we can still expand the 8 mm to 10 mm. So that is the reason why we kind of under dilate. We just use an 8 mm to dilate the track. And once we dilate the track, we deploy the stent. So that's the TIPS procedure. So here, this particular patient, we had to use 2 stents for some other reason. But this is how the TIPS procedure is done. So technically, again, it is not as challenging as it was in the past, because of the advancement of the technology. We use ultrasound guidance. We can puncture the portal vein, and we can have a roadmap of where the portal vein is. We can use CO2 angiogram to see where the portal vein is. So definitely, it is technically not so demanding these days as compared to how it was in the good olden days. Now, again, in pediatric patients, sometimes the case that I'm going to talk about is the case of DIPS. What are the advantages of DIPS over TIPS? Because we had one patient of Budd-Chiari, I think child was about 9-year-old, pre-transplant, and I think refractory ascites, and the hepatic veins were completely thrombosed, so we had to go for DIPS. And the advantages of DIPS over TIPS is the fact that the shunting into the larger IVC, it avoids chronic issues of hepatic vein stenosis. Sometimes you can have stenosis of the hepatic vein even after deploying the stent when you go for TIPS procedure, especially in Budd-Chiari patients. So in Budd-Chiari patients, DIPS probably has got a little bit of an advantage over the TIPS procedure. And again, the tract is a little short in DIPS between the cava and the portal vein. It's a fairly short track, and because the track is short, the patency rate is even higher for DIPS compared to TIPS procedure because of the short liver parenchymal shunt. So it is less susceptible to any kind of pseudointimal hyperplasia. And so there are various techniques. I would probably skip this to, but just to show that the advancement in technology, there are various techniques that we use for TIPS. One is the ultrasound guidance, and sometimes, let's say, if this is a portal vein that you're seeing, we can puncture the portal vein, and where the star is the cava. In TIPS procedure, we need to connect these two up, cava to the portal vein. So it is, it's very difficult to, aim at the portal vein coming from the cava. So what we can do is we use a retrograde approach. In the retrograde approach, we can puncture the portal vein first, and from the portal vein, directly the needle is shot towards the cava, and we retrieve the wire from the top end, from the IJV. For example, as the arrow points there, you can actually puncture the portal vein, and from the portal vein, the needle is passed all the way towards the cava, because we have a sheath from the jugular approach inside the cava. So we target the sheath and we aim for the cava from the portal vein towards the cava. And once we puncture the cava, the wire is kind of let into the cava, which is retrieved from the top end, which is retrieved into the IJV. So now you have a track, now you have a wire which is going from the portal vein into the cava, and which is kind of comes out of the neck of the patient. This is called as a body flossing technique. So using this, we can pretty much connect IVC and the portal vein very nicely. And this is again TIPS procedure, which is performed from a left IJV approach. So this is how it looks. It can be a little kinky when we use this procedure, because you're puncturing the portal vein, and from the portal vein you're going towards the cava. So you can see the stent takes a longer route, and it has got a slightly tortuous appearance because of the technique that we have used. This is the other technique wherein you directly puncture from the cava towards the portal vein. If we are lucky, we can just hit the portal vein, and this is how it looks. And I think this is what we used in this particular child for doing DIPS procedure. And we balloon the track like we normally do. We measure it, and then we deploy the stent. So that is that. And one important thing that I wanted to mention is there are a lot of papers which say that when we actually do TIPS procedure, people ask me, should we just get into the varices and embolize the varices as well? This is the left gastric vein or the coronary vein, which is causing the varices in this particular patient, esophageal varices. So when we do TIPS procedure, do they automatically collapse, or do we need to get inside these varices, and do we need to coil them, is a question. But there are a lot of papers which show that, TIPS along with variceal embolization has got a better prognosis compared to just TIPS alone. And that is what they say. So, I mean, if it just gets in, if the wire gets into these varices, we can use an Amplatzer plug, we can use coils, we can use glue to block off the left coronary vein, so that the esophageal varices are also treated at the same time. And this is in cases of variceal bleed. So there's a large retrospective study which shows that variceal embolization at the time of TIPS significantly prevented the rate of recurrent variceal bleeding in comparison to TIPS alone. So this is what they say. And again, they found that prospective randomized RCT on TIPS alone versus TIPS with concurrent coronary vein embolization found a significant reduction in the 6-month overall rebleeding rate, favoring the embolization group. So, and again, the role of anticoagulation after the hemorrhage, again, it's entirely, there are no papers, to be very honest, to say, do we need to anticoagulate, especially for butt chiari? Obviously, we have no other choice. But if somebody comes with variceal bleed and then you do TIPS, do we need to anticoagulate? What, when, how long? Every institute, they have their own protocol. And our institute protocol, I mean, either we treat with warfarin, or you can put them on dual platelet therapy, aspirin plus clopidogrel. Depending on their coagulation parameters, we can consider one of them. And usually, the minimum that I would do is at least 3 months, of course, with a routine follow-up ultrasound every 2 weeks for the first 1 month, and later on every 3-monthly Doppler ultrasound to make sure that it is patent. As long as there is a regular screening, we don't have to worry about the patency of these stents, because the earlier we detect, we can definitely go in and unblock all these stents. The problem is if it goes undetected, if they don't come to us, when it's chronically thrombosed, that's when it becomes very difficult to treat them. But as long as they're under surveillance, as long as we screen them, I don't think we really need to worry about that. And this is how we do the follow-up, and that is for radiologists. And so transplant patients, as we all know, are different, and most patients have got benign disease and have potential for long-term survival, and resources are limited. So every effort should be made to salvage the allograft, as we know, and immunosuppression alters both response to infection and the healing process. Now, can I move on to the transplant, Dr. Ashwin, or do we need to stop
Yeah,
here?
sure.
Can I move on?
No.
Okay, fine.
Yeah, yes, please.
Yeah, okay, fine. So in terms of the post-transplant anatomy, I mean, I wouldn't go, you're all surgeons. I'm sure you all know better than me, so I'm not going to go into the details of the anastomosis, the different types of anastomosis. But as radiologists, for the radiologists who are watching this, I think it's very important we talk to surgeons and find out from them what they did, because quite often we are, when it comes to doing any kind of a post-transplant intervention, if we are clueless about what you have done, I think we'll be there sitting with the patient for ages. So it's very important that we get from the case notes, or we just discuss with the surgeons and get the right kind of anastomosis, whether it is because if you do a piggyback anastomosis, I can actually approach a piggyback from the femoral approach as well. If it is not a piggyback anastomosis, and I need to always come in from the top end, which is the IJV approach. So it really matters to us that when we discuss, we know what kind of anastomosis you do, so that we have an idea and we can get in quickly and we can save the life of the patients. And as we all know, the different types of piggyback anastomosis, for the sake of the radiologist, this is how it looks. So always make sure that you do a lateral screening when we actually do inject the contrast. Quite often when we see in the AP view or a PA view, we really don't know what's happening. So it's very important that we look at the sagittal view or the lateral view when we do an angiogram or when we do a venogram, to see where exactly the anastomosis lies, so that we can just get inside the patient. Now, in terms of the liver transplantation, so all the anastomoses are potential sites for stenosis. And if it is a vascular anastomosis, we know it can lead to stenosis or it can lead to thrombosis. Now, in terms of the frequency of anastomotic complications, biliary, fairly high incidence, then comes the hepatic, arterial, then you have portal venous, then the systemic venous. So overall, the vascular complications, they contribute to 9 to 12% of the complications. And biliary complications, as we all know, that most of the patients, usually 25% of the liver transplant recipients, usually within the first 3 months after transplantation, they may end up having biliary complications, are fairly common. And these are the second most common after the graft dysfunction, rejection being the most common thing. And I mean, we all know the kind of biliary complications that we can have. It can be stenosis, you can have fistulas, you can have obstruction, stone formation. Yes, it is still possible in a post-transplant setting, and recurrent biliary disease, again, something that we need to be aware of. And CDCD, which is a duct-to-duct anastomosis, is something that we get involved, that we don't get involved that often, because this is approachable through ERCP. So quite often, if it is a duct-to-duct anastomosis, an endoscopist can get in and he can sort it out. So that is a preferred anastomosis, as you all know, for most of the cases, to preserve the sphincteric mechanism, and it allows a retrograde access. So we always have a backup plan, even if the patient is, let's say the patient is referred to us for PTBD. If we cannot do, we always know that, oh yes, there is ERCP, which is another technique available to treat this kind of problem. And so that's the duct-to-duct anastomosis, and we have the jejunal, choledochocholedochostomy is the other anastomosis that we have to do. We need to, get ourselves involved here, and wherein probably there is no role of an endoscopist here. And as we all know, this is done in sclerosing cholangitis or biliary atresia or duct size mismatch, or to repair a problematic duct-to-duct anastomosis. That's when the HEPJ is performed. And biliary complications, again, in terms of the leak versus obstruction, how we manage a leak, how we manage an obstruction, I'll demonstrate in the next couple of slides. The bile leaks, usually it's either from the biliary anastomotic site or from the cut edge of the liver because of the reduced size or the lobar transplantation. Now, the anastomotic leaks, if you look at the duct-to-duct leaks, I think this is a repetition of the slide again, I'm sorry. Looking at the anastomotic leaks, this is when do we interfere? If there is a leak, we interfere either to divert the bile flow using either our PTBD internal external drain or the endoscopic stent. If the T-tube is in place, you open the T-tube, or PTBD external drainage. If the leak continues with open T-tube, this is normally what we do, and we drain the biloma. So draining biloma and diverting the bile flow. These are the two things that we do when it comes to any kind of a leak. And if it is an anastomotic, sorry, I don't know why the slides are repeating. 80% of the anastomotic leaks will heal without any surgical revision of the anastomosis. So we all know about that. So there is no need to go for revision of the anastomosis because majority of these leaks will heal, provided we drain it and we kind of divert the bile flow. And 20% with complete anastomotic disruptions, of course, require surgical revision to CDG, but majority of them, they can be sorted with interventional radiology procedures. And again, anastomotic leaks with the HepJ. Again, the concept is again exactly the same. We have to drain the biloma and we have to divert the bile flow. Sometimes when there is a leak, all the ducts are decompressed. So when the ducts are decompressed, if we have to divert the bile flow using a PTBD technique, it can be really challenging to interventional radiologists. And what we can resort in such cases is puncture the jejunal loop. I don't have the images right now, but we did a case wherein we punctured the jejunal loop. And from the jejunal loop, we can get inside the bile duct and we can put a stent, we can put a drain from the jejunal loop. And puncturing the jejunal loop is not an issue at all because anyway, it's a sterile thing, so we can just get inside and we can do from a retrograde approach. So when the ducts are decompressed because of a bile leak, and when we cannot see the bile duct, we can always use a jejunal loop to puncture using an ultrasound guidance. We can beautifully puncture the jejunal loop and we can use a retrograde approach to get inside the bile duct. This was this is another patient recently, I think it was just 2 days ago, we did this patient wherein the pediatric child who had a collection there. This is a collection that you're seeing, which is a subdiaphragmatic collection. Now, just imagine the access to this collection is really difficult because you've got a bowel loop there, you've got the kidney there, you've got the liver, and you've got the lungs. And to make our life difficult, we've been asked not to go through the liver. So we cannot go through lungs, we cannot go through liver. So all the routes are completely shut. So how do we go? So what we can do in such scenarios is either we create hydrodissection by creating a window between the kidney and the bowel loop. We can inject some saline and 5% dextrose, and we can actually increase the space between the kidney, between the bowel loops. We need to literally inject about 1 liter. This was a child, so probably 300 ml would have displaced the bowel loop, and we can just get inside this collection. Alternatively, we can create pneumothorax because you don't want to go through the lung for this patient. So what you can do is you can create a pneumothorax, and that's what was created there. So an artificial pneumothorax was created for this child, and so that is that. So once you create a pneumothorax, getting inside this collection can be fairly easy. So after we created the pneumothorax, we got inside the collection, the drain tube is just there. And once you insert the drain tube, we can actually suck out the air because it's an artificial pneumothorax and you have just punctured the parietal pleura. Artificial pneumothorax is created when you only puncture the parietal pleura. When you puncture the visceral pleura, obviously it's a different thing. But here the visceral pleura is intact. So literally the lung will expand immediately as soon as you suck out the air. So this was bile leak and it was treated using an IR technique. And now moving on to the anastomotic strictures. What do we do with anastomotic strictures? Do we put a plastic stent? Do we put a metal stent? What kind of balloons do we use is something that I'm going to talk right now. So here, this is an anastomotic stricture, and this is the most common type of stricture with an incidence of 10%. And it's likely more technique than site related. And CDCD anastomotic strictures, usually, as I said, endoscopists, they can just go in and sort it out. And if they cannot, we do the percutaneous balloon dilatation, and then we put in our internal external drain. Now, if it is greater than 3 months following liver transplantation, or if it's a failed endoscopic or PTBD stenting, then obviously at that point, surgical revision should be considered. But if it is less than 3 months, usually we end up going in and trying to do our bit there. And that is with regards to the duct-to-duct anastomotic strictures. And this is one thing that I wanted to say, because sometimes the anastomotic strictures can be really, really fibrotic. They can be really difficult to sort out, especially with normal balloons. So what we have here is something called as a cutting balloon. And this cutting balloon has got small microblades that you cannot see here. Where the arrows are pointing to, those are called as a microblades. And these microblades, they cut off the fibrosis. So it's fairly simple. Instead of using a normal balloon, we can get inside and we can use this cutting balloon, and we can actually treat the fibrotic strictures by using cutting balloon cholangioplasty. When standard balloon dilatation is insufficient, cutting balloons can be used, and it may be undersized followed by conventional balloon. And this is a technique which is I think we used it for a couple of patients at our institute, and the results are good when we use cutting balloons for fibrotic strictures. The technical success rate is 63% compared to 85% for conventional balloons. But obviously in the long-term outcome, we don't know about that. And there are limited data on the long-term results of PTBD with balloon dilatation. And 70% patency at a mean follow-up of 30 months following 1 to 3 transhepatic balloon dilatations. And these patients, as we know, they come very often. They come every 6 weeks for repeat angioplasty. So I think we just need to be patient. We have to treat them repeatedly, because if it's a fibrotic structure, again, it collapses because we're not inserting a metal stent here. All that we are doing is we are putting a plastic internal external drain. And that is the reason when they come back to us again, it would have collapsed, and again, you would see a stricture. So a constant repetitive balloon dilatation will definitely go a long way. So every 6 weeks, we may have to do the balloon dilatation, either with a cutting balloon or with a normal balloon. And the result would be seen after 3 or 6 months from the time of the procedure. So that is with regards to the anastomotic strictures. Moving on, with regards to the Hep-J strictures, I've already told you we can puncture the rule loop and we can get inside, or we can directly puncture the bile duct. If the duct is dilated, we can puncture the bile duct and we can get inside the rule loop. And these differ as the operative repair is less durable, and these strictures should be approached more aggressively with non-operative therapy is what we feel. And cutting balloons again can be used with these kind of anastomotic strictures as well. Now this is one such balloon which was used, and balloon dilatation was followed by internal external drain for 4 to 6 weeks, 73% success at 2 years and 66% success rate at 6 years. And anastomotic strictures, again, do we use metal stents? Quite often, unless we think there is no other choice, we don't use metal stents, especially with our approach, because these metal stents that we use percutaneously are permanent stents. These cannot be retrieved. They are irretrievable. I mean, there are some stents available which can be retrieved endoscopically, but percutaneously we cannot. So what we can do in such scenarios is we can actually puncture the duct. We can leave the wire, and an endoscopist can come from the other end, and they can put in a retrievable metal stent. That is very much possible, but percutaneously, we don't have metal stents which are retrievable as of now. So that is about the anastomotic strictures. And the non-anastomotic strictures are, again, we know the reasons for non-anastomotic strictures. The most important thing is to look at the artery to make sure that the artery is not compromised, causing biliary ischemia and causing non-anastomotic strictures. And it's, again, when it comes to the technique, for us, there is no difference. It's more or less the same. We do PTBD and we do the balloon dilatation for non-anastomotic strictures as well. And patients with minimal symptoms and preserved synthetic function should not be treated. And balloon dilatation should be the primary treatment for symptomatic patients. It's a no-brainer. And stents should be reserved for failure, soft dilatation, and used as a bridge to retransplantation is a dictum here. And are stones common? Yes, biliary stones can be the cause of biliary obstruction in 5.7% of post-transplanted patients. So that's about the biliary complications. Moving on to the vascular complications. Some of these slides from some of my colleagues elsewhere, and also from some of the journals. So the locations, we all know that it can be hepatic artery, portal vein, cava, or the hepatic vein. And the reasons for the vascular complications, it could be intimal hyperplasia. It can be because of the multiple anastomosis. Reperfusion time also plays a significant role when it comes to these complications. It could be torsion. It can be because of a kink, technical factors, etc., etc. And hepatic arterial complications, 4 to 12% in adults and 42% in children. So in adults, it's less common compared to children when it comes to thrombosis. Hepatic artery stenosis, the risk is about 5% to 11%, and pseudoaneurysms, less than 1% of the cases. It could be infected or uninfected. This is, we all know about the importance of Doppler, post-transplant, intra-op Doppler, and then day 1 to day 3, and then every week. So it's very important we do the Doppler. And just to explain the parameters, and this is how the waveform should look like when you do the Doppler. Very sharp systolic upstroke, and then the diastolic is kind of very, again, it's not delayed. This is a diastolic stroke, that is a systolic upstroke. So the RI as we all know, should be 0.55 to 0.8. And the peak systolic velocity should not be more than 200 centimeters. These are the only two things that we need to be aware of, RI and the peak systolic velocity. If the RI is less than 0.55, that's when we would worry. If the peak systolic velocity is more than 200, that's when we would worry. This is again a little bit about what happens if the RI is more than 0.8. If the RI is more than 0.8, it can be because of reperfusion edema. It can be because of the cold ischemia time. It can be because of vessel spasm. So we don't have to worry about it. Generally, RI will normalize after 7 to 15 days. And just we need to follow up with Doppler ultrasound. But if the RI is less than 0.5, that's not good because the sensitivity and specificity is fairly high for short-term vascular complications. So we need to be really vigilant about low RI, especially less than 0.5. Now again, hepatic artery thrombosis, as we all know, preferred treatment is surgical thrombectomy with the revision of the surgical anastomosis. Most patients might end up requiring the retransplantation. But again, the early detection is the key. Can we do something about it? Yes, we can do hepatic artery catheter thrombolysis. If it is an early hepatic artery thrombosis has been reported, but it has got a slightly higher risk because the anastomosis is really fresh. So for us to go in and intervene for an early hepatic artery thrombosis, it's a little challenging. And that is the reason why the numbers are fairly low. We don't get that many cases of hepatic artery, transcatheter thrombolysis unless they feel that, patient is not suitable for repeat surgery or a redo. We don't get to do these things at all. But yes, there are one or two cases wherein we might have to get involved. And so this is the power status waveform that everybody needs to be aware of. If you look at the previous ultrasound picture, you had seen that there was a very sharp systolic upstroke. And here the acceleration time is fairly long. It's more than 80 milliseconds. And this is called as a power status waveform. When we have a power status waveform, that's when we worry about something. That's when we worry about stenosis. And if you see a CT of this particular patient, you can see that this is filling up distally, but there is nothing that you can see here. So this is hepatic artery thrombosis. Can we do something about it? Yes. This was a pediatric patient wherein, we can get inside and you can see on the initial angiogram on the left-hand side, nothing was seen. But later on, you can see that the branches started filling as we negotiated across the anastomosis. You can see angioplasty must not be performed if the anastomosis is fresh. What we can definitely do is we can consider transcatheter thrombolysis. We can always thrombolyze it, but again, thrombolysis is again contraindicated if it is, if it's surgery. It can be an absolute contraindication in certain cases, but it's a clinician's call. What we should be doing if the patient is not suitable for a redo, we may have to take a risk and we may have to do this. So this is what it is. And sometimes if the anastomosis is not fresh, we can definitely go in. If it is more than 2 weeks old, then we have no problem using a balloon. We can get inside and we can actually do the angioplasty. And this is how the perfusion is restored with balloon angioplasty. And hepatic artery stenosis, usually we know it occurs at the site of anastomosis within 3 months. If it is left untreated, it can lead to hepatic artery thrombosis, ischemia, biliary sepsis, and graft loss. And cholangiographic abnormalities are definitely present in 60%, usually non-anastomotic strictures, and are fairly common with these kind of things. And it can lead to sludge and it can lead to debris, and you see multiple abscesses inside the liver. So these are all the patients who might be really difficult to treat with. And what you would see on the ultrasound is a peak systolic velocity of more than 200 centimeters per second. It is definitely suggestive of a stenosis. More than 50% of the stenosis can give rise to a peak systolic velocity, which is more than 200 centimeters per second. Obviously your RI will be less than 0.5. So the angioplasty should be initially attempted if it is a hepatic artery stenosis, depending on the age of the liver. And we can actually put in stents with no problems. We have balloon expandable stents to get in and put inside the hepatic artery. So this is a case wherein you can see a stenosis there, and you can see the peak systolic velocity at the site of the stenosis is more than 200, and this is what you would see on the ultrasound, and that is indicative of an imminent stenosis, or rather a stenosis. And you would just go in, and on the CT you can see that this is there, and you can go in and you can do the balloon angioplasty. If the graft is a little older, we can definitely go in and do the angioplasty. And again, this is another case wherein if there is an abrupt cutoff, you're not seeing anything beyond the first 3 or 4 centimeters, case of stenosis, again, we can just get inside, use a wire, and we can plasty it, and this is how the flow can be restored for hepatic artery stenosis. So the technical success with hepatic artery stenosis is 80% to 90%, and there is an improvement in 40 to 60% of the cases, although retransplantation is frequent in such cases too. So this is a stent which is deployed for stenosis, especially if it is so ragged like this. Angioplasty is not going to work. If it is ragged, then we need to make sure that this whole thing looks defined, and for that, stent needs to be placed in such cases of hepatic artery stenosis. So again, the results, we don't have a lot of data, a lot of literature on hepatic artery stenosis because significant number of patients are lacking. We don't do this on every single patient, so we don't have enough numbers to really say about the patency rate. But up to 25 months has been reported in those subset of patients who had this hepatic artery stenting. Again, another thing which can go wrong is a hepatic artery pseudoaneurysm. Now, if there is a pseudoaneurysm like this, it's not necessary that we need to go in and put a stent across like this to sort the pseudoaneurysm. What we can do is we can inject thrombin. If somebody has got a femoral artery puncture, if there is a groin pseudoaneurysm, percutaneous thrombin injection is a well-known and well-accepted form of treatment. So we can also get inside this hepatic artery pseudoaneurysm percutaneously using CT guidance or using ultrasound guidance. Transhepatically, we can get inside this particular pseudoaneurysm and we can actually make it completely thrombosed. So that's a very simple thing to do rather than putting in a stent. It can be a very expensive job if you have to put a covered graft. So this is again one simple thing that we can do using a thrombin injection. So that's a reconstructed image which shows a pseudoaneurysm in the hepatic artery. Now, one important thing when it comes to hepatic artery that we need to understand is the splenic steel syndrome. Sometimes we see that the hepatic arteries are so tiny compared to the splenic arteries, and when we actually do Doppler, we'll be struggling to find the hepatic arteries. In those scenarios, it is important that we understand that it can be splenic steel as well. It is a non-occlusive hepatic hypoperfusion syndrome, and the reported incidence is about 5% with 94% of the cases in the first 2 months. So what we see is a diminished hepatic arterial flow and a very prominent splenic artery. And this is usually seen in patients with pre-existing portal hypertension and significant splenomegaly resulting in hepatic hypoperfusion. So this is one such case wherein you can see the hepatic arteries are really tiny, but you see this chunky splenic artery. So what we need to do is this treatment is really simple here. We are technically not demanding at all. We just need to get inside the splenic artery and do a proximal embolization. We can use a coil, we can use a plug, and we can do proximal embolization so that we divert the blood flow towards the hepatic artery. So that can be very easily treated. And again, there is the way to identify this is looking at the splenic artery to hepatic artery ratio. If it is more than 1.6, that means the splenic artery is 1.6 times the size of the hepatic artery. That's when it is considered as a risk factor for splenic steel syndrome. This is another view of the same thing wherein you can see chunky vessels, chunky splenic arteries. And again, imaging findings are fairly non-specific. On angiography, what you see is a flow predominance towards the splenic artery with early preferential splenic parenchymal perfusion, and this is what you would see. And you will also see portal venous flow occurring simultaneously with the splenic arterial flow. This is a key thing when it comes to angiogram, because sometimes you don't see the hepatic artery filling. Even before the hepatic artery fills, you would see the portal vein and the splenic artery filling up, and that is one of the key things to observe when you do an angiogram in such cases. Moving on to now we are done with the hepatic artery. I'm just moving on to the portal vein. The portal vein, again, we all know how the portal vein flow looks like. It's monophasic, it has to be hepatopetal, and you see this continuous phasic spectrum on the ultrasound. And we know the velocity of the portal vein as well as to how much it should be. But if you see the velocity of the portal vein, which is showing a significant increase like this, then we have to suspect portal vein stenosis. Especially if there is if in the post-stenotic segment, you see the green multiple areas, that's a turbulent flow. When you have this turbulent flow, you see multiple colors on the ultrasound, on the color Doppler. And you will also see the flow is significant. So in the post-stenotic segment, if the velocity is more than 200, it's literally 360 centimeters here. And in the pre-stenotic segment, you see the velocity is 36 centimeters per second. There is such a discrepancy between the both. You definitely have to suspect portal vein stenosis. And this is one such case wherein there is a stenosis of the portal vein. And again, the treatment is very simple. Percutaneous approach, we puncture the portal vein. As long as there is no ascites, we don't have to really worry much about the complications. If there is ascites, that's when it makes our life a little difficult because of the risk of bleeding. But again, the portal vein puncture, the risk of bleeding from the portal vein puncture is fairly minimal. So we can go in, we can puncture the portal vein, and we can use a balloon. And we have these balloon expandable stents as well, wherein as soon as you deploy the balloon, the stent gets deployed along with the balloon. And this can be done for portal vein stenosis. Post-stenting, again, you can see that there is a significant reduction in the drain volume of this particular patient. It dropped from 2000 ml to 300 ml per day, and it stopped within a week. And there was a significant reduction in the portal vein velocity was seen after the stenting. From 360, it came down to 89 centimeters per second. But unfortunately, this particular patient, this is not from our institute. This is from one of my colleagues that I got. He developed an anastomotic biliary leak, for which they had to put in an external drain for the persistent leak. So this is a case of a portal vein stenosis with a portal vein stenting. Portal vein stenosis or portal vein thrombosis incidence is less than 2%. As I said, it's usually biliary and the hepatic artery, which is very common, and most commonly results from technical problems, or because of the differences in the caliber of the anastomosed vessels, or because of the stretching of the portal vein at the anastomotic site, previous portal vein surgery, previous thrombosis, etc. If it occurs within 1 month of the transplant, hepatic dysfunction and hepatic failure may be observed. And if it occurs later, we can see sequelae of portal hypertension, like bleeding, ascites, encephalopathy are usually the presenting symptoms. So as radiologists, we feel it's very important we ask the clinicians the exact history as to what exactly the patient presented with, so that we know what exactly is happening, whether it happened within a month of a transplant or more than a month of a transplant, and whether it correlates with the clinical history is something that we all ought to make as radiologists as well. And diagnosis is usually, as we know, it's made by surveillance ultrasound. Now, portal vein stenosis or thrombosis, something that we often don't get involved is, I don't know why, but out of India, we have done several cases of portal vein thrombolysis in the context of portal vein thrombosis. It's again very simple technique to do. We can just get inside the portal vein, and we have these devices similar to stroke thrombectomy devices, all these newer devices, newer catheters, newer gadgets, wherein we can just get inside the portal vein and we can suck the thrombus out. We don't have to put the patient on heparin. We don't have to put the patient on long-term anticoagulation, waiting for the portal vein to become patent. If it is an acute portal vein thrombus, it can be resolved within 1 or 2 days by using these newer agents and newer devices. We have mechanical thrombectomy devices. So that is something that we all ought to consider if somebody has got a portal vein thrombosis and if it is acute. When I say acute, usually less than 14 days. Up to 14 days, we can go in because the clot is still mushy, and we can go in and we can absorb and we can suck the clot out. This is one of our cases wherein a patient had a portal steal post-transplant. I think this was a 12-year-old, if I remember correctly. So early allograft dysfunction due to portosystemic shunting and decreased portal flow compromising graft is quite an interesting case, actually. So this was a 12-year-old child with biliary atresia, and it was a failed Kasai, and then he underwent LDLT on 25th of February. And post-transplant, Bili came down to 4, and then gradually it went up. So the biopsy showed it was rejection, and we diagnosed portal steal syndrome only because of this. I'll just show you what I mean by that. So you can see the portal vein on the scan. Portal vein was fairly atretic. You can see that the artery was probably bigger than the portal vein. Generally, you would see that you can hardly see the artery, especially here. But what you're seeing is you're seeing the portal vein, which is probably equal size as the artery, very thinned out portal vein. And what you see here is there is a large shunt. There is a portocaval shunt. There is a systemic collaterals, multiple systemic collaterals, and sorry, it's a splenocaval shunt that you can see. So what's happening is everything is getting diverted into the shunt, and nothing was getting inside the portal vein. So there was a hyperperfusion because of the portal steal. So what we actually did in this particular case was we just wanted to do portal vein stenting for this patient so that we can actually improve the caliber of the portal vein. But unfortunately, I ended up giving a complication here. I punctured the artery, unfortunately, because the artery and the vein, they look the same on the ultrasound. And what I thought of as a portal vein turned out to be artery after puncturing. So this was the arterial puncture. And later on, we realized it was an arterial puncture, and we sorted it out later. But then I had to puncture the portal vein from another approach. And this is a punctured portal vein. And what you would see on this particular movie is, when we injected the contrast into the SMV, everything was escaping into the systemic circulation. Nothing was getting into the portal vein. So this is a flow, and that is a flow dynamic. So it was a portal steal, very clearly portal steal happening here. And so what we did is we deployed a stent, and later on surgically, the collateral was also ligated, because they had to sort the hepatic artery. The chaos which was created by me had to be sorted out. And so that was sorted, and the collateral was also ligated during surgery. But the patient ended up having a portal vein stent anyway. So this was a case of a portal steal, which happened in this particular child. And this is another interesting case wherein a patient, it's a post-LDLT, patient had a HepJ, and it was a small foci syndrome with graft dysfunction, and he developed hepatic encephalopathy. And again, this patient had a portocable shunt, which was kind of, there was a portal steal because of the portocable shunt, which actually was still working post-transplant. So what we did in this particular case is we actually blocked off the shunt, portocable shunt, using something called as an Amplatzer plug. So Amplatzer plug is something which can be deployed from the cable approach or from the portal vein. By puncturing the portal vein, we can get inside, we can reach the anastomotic site, we can reach the portocable shunt, and we can deploy the Amplatzer plug. And this is how it looks on the CT following the deployment of the Amplatzer plug. So that was the Amplatzer plug which was deployed in a case of a portal steal via a portocable shunt. And these are the different types of Amplatzer plugs which are available in the market, and we can choose anything, and we use one of these plugs to block of these shunts. Again, this is another interesting case, which was, I think, probably Dr. Ashwin, you'll remember this case. This was our article in Liver Transplantation Journal, minimally invasive treatment of metabolic decompensation due to portal steal in auxiliary liver transplantation. Quite often, if somebody has got an auxiliary liver transplantation, you know that there is a ligation of the portal vein anyway, and you expect the graft liver to grow. But in this particular case, unfortunately, there wasn't a good response of the graft liver, and the blood was diverted to the native liver. And what we did in this particular case was we did a selective right anterior portal vein embolization so that we can improve the blood flow to the graft liver and also to the right posterior portal vein. So this was a selective portal vein embolization in a case of an APOLT, wherein we had to divert the blood flow to the graft liver and also to the right posterior portal vein. So that is a very interesting case of portal vein embolization. And in terms of, we finished off with the arterial anastomosis, portal vein, and now moving on to the systemic venous complications. Incidence is not that much, it's less than 1%. You know the various locations where we can have this problem, IVC, hepatic veins, or it could be combined IVC or hepatic vein, especially if it's a Budd-Chiari, it can make it really messy for all of us. So it can be suprahepatic cava or infrahepatic cava. And again, I feel as a radiologist, we need to be aware of the clinical signs and symptoms. If it is a suprahepatic cava, usually, patients can present with ascites, portal hypertension, and mild hepatic dysfunction. If it's an infrahepatic IVC stenosis, usually it leads to lower limb edema. And the treatment is venoplasty and stenting. And hepatic vein and IVC complications, as we know, have an incidence of 1.2%. Something that we need to be aware of is an extrinsic compression because of the graft swelling, because of the hematoma, because of the fluid collections. It's not always because of the anastomotic problem. It can be because of an extrinsic compression in the immediate, perioperative state. That's something that we need to be aware of. This is one such case wherein you can see there are a lot of, you can see that there is a loss of facity. It's a monophasic flow. These three are the hepatic venous forms on the top. And at the bottom, you're seeing the IVC waveform. What you're seeing is an increased IVC velocity in the post-anastomotic segment with a decreased velocity in the pre-anastomotic segment. This is the piggyback anastomosis that this patient had. What you're seeing here is where the purple arrow is pointing to, there is a very small hematoma which is actually compressing the cava. When a hematoma compresses the cava, you can have a narrowing like that, and that can give a lot of symptoms that the patients can present with. So what we can do is, the most important thing in this context, when you see an ultrasound abnormality, is to make sure you do a CT scan and identify that, because CT can help, in looking at the congestion of the liver. This is how the liver looks. It looks so congested. It's got this typical mosaic pattern, especially in Budd-Chiari patients. You see something like this, and what you're seeing is a very narrowed segment of the cava there. And again, it's very simple to treat. We just need to use a 16 mm balloon or a 20 mm balloon for an adult patient. We can do a plasty. Plasty, it may not sort it out, so we may have to end up stenting. But stenting again has got its own problems, own complications in Budd-Chiari patients because they can get thrombosed. So again, it's a call that we have to take whether we need to go in for stenting or just do plasty, repeated plasties, and then save the patient, or do the stenting. So that is the IVC cable complications, and we can also have non-anastomotic complications. I finished off with the vascular complications. I'm talking about the other infective collections. The infective collections are fairly common with a significance less than 25%. The conservative management is required for small non-infected collections. As I showed in the previous slides, we can use ultrasound or CT guided drainage to drain collection from any part. We can, these days, we can pretty much get inside any collection for that matter, because the techniques have improved. We have a lot of methods like hydrodissection, creation of an artificial pneumothorax, creation of an artificial hydrothorax. So we can get inside the collection from various approaches. So we really don't have to worry about gaining access to the collection because of the improvement in the techniques. So this is a fairly easy collection to treat. So it can be as simple as that. It can be very difficult collection with a hilar collection as well. So, no matter where it is, we have our own technique to get inside the collections and treat these patients. So neoplasms, do we have neoplasms post-transplant? How common are they? If you ask me this question, I think I have seen only one patient so far who came to us with recurrent, with a HCC in a transplant liver. And that patient is actually doing well. He had repeated cases and repeated tears and is actually doing pretty well. Otherwise, neoplasms, I haven't seen many cases, but this is a reported literature rate wherein you can see, reported recurrence rate is definitely less than 10% according to this. And do we do TIPS post-transplant? I haven't done, I don't remember doing a TIPS case post-transplant, but according to this particular study, they showed, there is actually no difference. Two case control studies, they compared the transplant TIPS group with the non-transplant patients undergoing TIPS. What they showed is a higher infectious complication rate in the post-transplant group, as well as a high hepatic encephalopathy rate and a poor one-year transplant-free survival of 14%. So I don't have much experience with this. And the clinical success rate for TIPS was significantly lower for transplanted patients compared with non-transplant patients. So there's no point actually going in for TIPS if there is a recurrent ascites or if there is some problem post-transplant. The clinical success is not that great. So probably refrain from doing TIPS unless it's absolutely required. So in conclusion, the overall success rate of a liver transplantation program is strongly correlated with the availability of an interventional radiology expertise. And transplant patients do not have the same immune and healing responses as non-immunosuppressed patients, more likely to leak, more likely to develop infections. Reoperations on this patient population for anastomotic revision is often difficult. Therefore, an aggressive percutaneous approach is often warranted. And these are the references if you want to go up and look at some of the articles. And that's about it. Thank you so much.
Thank you, Dr. Deepa. It was an amazing exposition of the role of intervention radiology in liver transplant.
Thank you.
It's a very broad topic which you have sort of very expertly covered. And if you can stop sharing a slide, then we can maybe have a few questions going back and forth.
Yeah.
I can see Dr. Reddy in the audience. And can I have Dr. Reddy and Dr. Ilango, if you can switch on your camera. Dr. Srinivas Reddy, are you there?
Yeah, I'm here.
And Dr. Ilango as well. My first question to Dr. Deepa would be, in small tumors, it's always a commonly asked question, RFA versus TACE. What would you do? And you could do both, I mean, and assuming it's in an ideal location, not near the gallbladder, not near the diaphragm, not near a blood vessel. Would you do RFA? Would you do TACE for a tumor less than 3 centimeters?
If it isn't, for a tumor less than 3 centimeters, I would definitely prefer RFA compared to TACE because it's a fairly simple procedure. The results are good, and we don't have to worry about breaching the capsule, as I already said. So RFA is definitely a gold standard In fact, it is curative for patients with tumors less than 3 centimeters.
Sure. Yeah, if I may ask Dr. Reddy, what would you ask the intervention radiologist not to do so that, you know, our intraoperative field or, you know, the explant is not complicated? Like say, um, um, I, I remember you always warning us that, you know, the artery can dissect if there's a TACE. So are there any particular things they should not do, Dr. Reddy?
No, I mean, I don't think we can say tell them radiologists what to do and what not to do. They have to do it safely and not to make too many attempts. And it's also nice to know when you're operating which artery was actually accessed, so that you can, if possible, you can avoid that artery to the anastomosis. So if they've gone through the accessory right artery, then we do the anastomosis to the main hepatic or the other way around. So I think that's something that it's nice to know from the intervention notes as to which artery they accessed.
And are you okay with RFA as well with regards to an explant? Which would you be more comfortable with, Dr. Reddy?
No, I don't think that it should make a difference. I think it depends on what the aim of the treatment is. If it's a small 1.5 centimeter tumor, and we're not actually thinking of transplant, and we're thinking of RFA as a treatment as a definitive approach right now, I think RFA would be better, or RFA along with TACE. But if you're looking at more as a bridging procedure, or if there are multiple lesions, then probably TACE is a better option, especially if the patient is going to go for transplant.
Sure, sure. And we spoke about TACE as a bridging procedure. Have you used TARE, Dr. Deepa, with an aim to sort of transplant the patient in the future, not with a palliative?
I think there were couple of patients that we did tear on. In fact, they had multiple lesions. In fact, the family also wanted tear for whatever reason. So if they're affordable, yes, why not? I did do on a couple of patients, and we downstaged the tumor in such cases as well. Yeah.
And are the two procedures quite similar to do, TACE and TARE?
They both are similar, except for the cost would be. It's just that there is one study that we need to do prior to TARE procedure, which is a lung shunt study. The lung shunt study is technically it's a mapping angiogram that we do prior to TARE procedure, so that we are aware of the shunting. If the lung shunt is more than 20%, they are not suitable for the TARE procedure. So this is an additional procedure that we have to do for all TARE patients. But other than that, technically speaking, there is no difference between TACE and TARE. But definitely TARE has got an advantage compared to TACE. If you forget the cost, TARE has a better advantage over TACE, only because the systemic side effects are less with TARE compared to TACE.
Okay, thank you. And I'm always quite interested. When would you do a BRTO, the retrograde occlusion of the veins, and as compared to a TIPS and for a bleeding varix?
Yeah, if it is an isolated gastric varices, if there are no esophageal varices, if it's an isolated gastric varice, then definitely BRTO is an option. So and also that is a main indication, because technically speaking, we are not creating any shunt here, so it's very easy to do for us if it is an isolated gastric varix.
And we spoke about TIPS, isn't it? I mean, and you gave quite an exposition about it. I'm quite interested to know. We normally use it for ascites or for refractive bleed. Is there any role of TIPS or to treat sarcopenia in those who are awaiting a transplant? Any experience in that?
Sorry, Ashwin. Actually, I couldn't hear anything. It completely broke. So
all right.
Just 1 second. I think I might have to carry this laptop somewhere so that where the internet connection is stable.
And,
so I can't hear.
Reddy that question, because he has extensive experience with sarcopenia. Dr. Reddy?
Yeah.
Ashwin, I mean, I think what you say is theoretically feasible because most of these patients are on the waiting list. They're getting repeated parasitosis. They're losing lots of protein with ascites, and they get more and more malnourished. So I think theoretically speaking, you do a tips and reduce the frequency of paracentesis, you're going to decrease protein loss and improve sarcopenia. But I don't know if this has actually been done or this is just a brainwave that you got today.
Sorry, what was the question? What was the question, Ashwin? I can hear you better now. So
the question was, we normally use tips for ascites or for refractory bleed. I was just wondering, we do have patients who are very sarcopenic. So this is one of the, I mean, it could potentially reverse sarcopenia.
yeah.
Wondering if you have any experience or any literature.
Actually, it's the other way around, isn't it? I mean, generally, we're not supposed to do tips for sarcopenic patients because the tips-related mortality is fairly high in, they can go into encephalopathy if there is sarcopenia, isn't it? So we don't actually offer tips if the patient is extremely sarcopenic. And I think Dr. Reddy also, he came up with this index on the CT scan, diagnosing sarcopenia using the psoas muscle on the CT scan to look at the sarcopenia index as well. So we had one patient, if I remember, maybe 4 or 5 years ago, wherein we offered, it was extremely sarcopenic and we did tips and he ended up having encephalopathy. And we had to go in and we had to block off the tips immediately for this particular patient.
Dr. Ilango, are you there? Do you have any views on this from your experience in UPMC maybe? I think he's not. Dr. Pari, yes, sure, go for it. You need to unmute yourself.
Hello, everybody, and thanks, Dr. Deepa Shree, for that wonderful talk. Coming to the hello. Yeah, am I audible? Yeah, okay. So sarcopenia, yeah, I think that's recent concept is that the tips seems to improve sarcopenia to a great extent. But in my understanding, it's almost never done solely for sarcopenia improvement. It's actually a byproduct of tips being done for ascites or bleeding. And what we have seen is probably as a byproduct, the patients tend to improve nutritionally and sarcopenia improves. And I'm not sure whether somebody would do this tips solely for sarcopenia treatment, but true, it helps in patients with intractable ascites and HRS who undergo tips, that sarcopenia helps. I mean, is improved with after tips. So I'm not really sure whether somebody does tips only for sarcopenia as an indication.
No. The other question was, you spoke about pre-operative and post-operative. Have you been called intraoperatively for any intervention radiology procedure?
Yes. Yes, I mean, I don't remember in the context of liver transplantation, but yes, quite often for resections, when we have to go in and do the ablation for, the ones which are not, which are unresectable, especially if you're deep-seated tumor, we have offered ablation in certain scenarios, but not in the context of transplantation.
Dr. Reddy, what is your opinion about intraop portal vein stenting for small portal veins in children? Do you think it's a feasible option which we should explore?
No, I mean, it is done quite frequently in the Far East, I think. I mean, the Japanese, the Koreans, even some of the centers in Delhi, they've used it, especially in the pediatric setting. But I think it's not a long-term solution. You can get the child out of the operation theater with that, but I think we're looking at a graft that's going to keep the child well and alive for the next 30 35 years. You won't need to do something better than just put a stent in, because the stent will not increase in size. Because Rela always says that the child grows, the portal vein has to grow. You can't just put a stent and say this is enough for a 1-year-old child, it will be enough for a 25-year-old male. So we've always had this preference for surgically sorting out any small portal veins, either with a jump graft or an interposition graft, and we had good results. So far, we've not had to use intraoperative stenting for any case. But I mean, it is done. It is done, and they've reported good results with it in Korea and Taiwan.
Any other questions from the audience? Any thoughts? Any comments? Dr. Pari, Dr. Ilango.
Ashwin, I think when we were discussing about RFA versus TACE for small HCCs, I think agreed that this is a intervention radiology session. I think the upcoming thing is SBRT, stereotactic body radiation, and we've seen that SBRT with the latest available machines and the techniques that they now they're able to use, I think they also give a fantastic results, especially for those tumors which are in a little difficultly accessible locations. So I don't think we should neglect that modality SBRT. Small lesions, pre-op, we don't need to worry about puncturing, tract site metastasis, and various other things that we were discussing. SBRT is one thing that I think is coming up.
Sure. I think Dr. Deepa can expand her repertoire into the radiotherapy field as well.
Yeah, SBRT. I mean, yes. I mean, it's coming up right now. But one area where SBRT might be really useful in somebody where there is a malignant portal vein thrombus, and if the bilirubin, let's say, is more than 5, and we are unable to offer TACE in such patients, we can definitely consider SBRT. In fact, there is a combination treatment, combination of TACE plus SBRT has got the better outcome compared to just SBRT alone or TACE alone. There are a lot of papers on that. But yes, if the bili is high, SBRT definitely has got a significant role. But otherwise, we prefer our own approach anyway.
Dr. Deepa, this is Dr. Ilango. My question is when you do the catheter thrombolysis for hepatic artery thrombosis, what is the dose that you use on a routine basis?
Yeah, we use altiplase. So few people use urokinase as well, but we use altiplase. And the dose that we use is we can give a bolus dose of up to 5 milligrams to 15 mg, depending on the body weight of the patient. The maximum dose allowed is 15 milligrams. And after you lase the thrombus with altiplase, we use something called as a fountain catheter, which has got, it's like an irrigation catheter with a lot of side holes on it. And we leave the catheter inside, and the dose is 1 milligram per hour for 24 hours. And we also use concomitant heparin infusion. So through the sheath, we run the heparin infusion at a rate of 500 to 1000 units per hour. And the TPA should be run at a rate of 1 milligram per hour for at least 24 hours.
Thank you. That was a good tip.
Thank you.
Any other questions from the audience? Dr. Reddy, would you like to make a comment?
No, I think it was an excellent talk, Dr. Deepa, and I mean, we have a lot of get a lot of help from the department in making sure our patients get through safely. And thank you very much. I think that's all from my side.
Thank you. Thank you so much.
Any other questions? Patta sir, again, we've been at it for an hour and a half. Every session has been like this.
Yeah, it's a lovely session, complete, and of course, Deepa is a very good speaker and she's done a great job.
Thank you, sir.
Thank you. Thanks.
If you have no further questions, then we'll end the session. Dr. Deepa, thank you so much. It was a fantastic talk by you, and I am stunned that you were able to talk for an hour and a quarter without a break. And it was all solid material, and it was very useful.
Thank you.
Dr. Ilango, Dr. Reddy, and Dr. Pari for your comments. We'll meet again next week. Thank you.
Thank you so much. Thank you all. Thank you. Bye-bye. Bye.